Hello, we put this video tutorial together demonstrating how to use our Blister device for research into keratinocyte physiology or to use it as a blister challenge model for immunologic activity. So step one, you're going to have the patient come in and get comfortable. Make sure to explain to them that they need to use the restroom before the apparatus goes on, because once it's hooked in, they will be connected for about 2 hours, and that can be challenging to move them if they need to go after the device is in place. Once you have them sitting, go ahead and clean the arm off with an alcohol wipe. Then you're going to want to remove the 3D printed suction blister apparatus. All of the instructions on how to obtain these are written within our publications, and we'll post them in the comment section below. You can autoclave the entire thing as one piece along with the straps, and it takes a little bit of finagling to get the straps on. Other people have used Velcro based straps, but we like these because of their ability to be autoclaved easily. So you're going to want to go ahead and strap them down. They do not have to be incredibly tight. You do want it to hold the device firmly in place, but the vacuum itself is going to do most of the work. After you get them set up, you're going to want to go ahead and connect the tubes to each side. Once you turn everything on, you're going to ask them to kind of keep this arm basically motionless. So have them set up with a TV or their reader, their phone, whatever, in the other hand. Turn it on, and you'll see the pressure start to build. We leave it at 30 millimeters of mercury for about 2 hours. So that's what I'm saying. They just going to sit here for 2 hours. So once they are complete, you can disconnect the tubes after turning everything off. Remove the straps. You might want to have a gauze or something ready, since occasionally the blisters will rupture during the procedure and some fluid might leak out. If you're not doing this in a place that has a sterile armrest, you may also need to have like a chuck underneath. But after you remove it, this is about what they will look like. And from there, using sterile techniques with scissors and forceps, you can just cut the keratinocyte roofs off directly. You can also collect the neat fluid, the fluid that is responsive to the immediate blistering, and run that for analysis, which will tell you some innate immune functions. So if you've collected the keratinocytes, you can put them through various models, which we've detailed in our recent publication seen here. One of the first things you can do is, with the keratinocytes roofs, you can incubate that in trypsin for about 5 to 7 minutes. You want to preheat the trypsin to 37 degrees and then incubate at 37 degrees for that 5 to 7 minutes. After those 5 to 7 minutes are up, you're going to want to stop the reaction with any media that contains 10% serum, and from there you can culture the keratinocytes. You'll see multiple different versions of keratinocyte culture. Some will use irradiated fibroblasts as feeder cells, which is what we did in our publication. Other publications will just put them straight onto collagen-coated plates. However, it is important that if you're going to try to expand the suction blister keratinocytes, that you culture in the presence of a Rho kinase inhibitor. You can see from our publication on the top level, there is the suction blister keratinocytes SBK. The early passage early passage plus the rho kinase inhibitor that we used. It's called Y27632, and then a late passage with the rho kinase inhibitor. If you don't have the kinase inhibitor, you won't even be able to make it to late passage because the cells will go through terminal differentiation and it won't allow you to expand your initial population to the point where you might want to have lots of cells for multiple different conditions. So if you're going to keep them in culture for very long, you're going to need to use some kind of rho kinase inhibitor or some terminal differentiation inhibitor. You're never going to get the same kind of results and the same kind of expansion we see with foreskin keratinocytes, but the suction blister method allows you to derive primary keratinocyte cultures from patients who may have genetic disorders. It also is going to be the only way in which you'll be able to use primary keratinocyte cultures from females, unless you want to perform surgical excision of skin samples. So if you don't want to expand the keratinocytes, you could also take the roofs and perform direct RNA extraction. You can turn it into a single cell suspension and perform flow cytometry or any other that you deem useful. Just understand that in the initial blister roofs, there will be some, although few, dendritic cells. Now, in our lab, we sometimes just take the keratinocyte roofs and harvest that for experimentation, but with this blister model, you do have the option for a blister challenge to be performed, which we've described some of the results of in these other papers shown here. Supplies you're going to need include a duoderm patch, some of 3D custom printed caps, a autoclavable paintbrush, a 10 millimeter punch biopsy, and a 3D printed template. So you take the duoderm, you lay it flat, place the template on there, open up the 10 millimeter punch biopsy, and simply through the template, you're going to want to go ahead and punch and remove the entirety of the foam insert. Occasionally, one will get stuck and you might need to pull it out of the way to finish. Just be careful. The punch biopsy tip is sharp. Once you have all of those holes complete, you can flip this over and begin inserting the metal caps. All of this you can do, maybe 5 or 10 minutes prior to removing the device and the suction as the patient is finishing up. But it doesn't take long if you want to wait and do it after you've got the entire area surgically excised and ready to go. We use a device with 8 wells. You can also purchase the device with only 4 if that works better for your needs. So the thing you're going to do right before placing it on the arm is use Dermabond. So you pull it out, you crack the inner well, and that allows you to drip the glue out. Because the inside of the package is sterile, it's safe to simply eject the glue directly into the packaging. From there, you're going to take out the autoclavable paintbrush. This is going to be single use at this point, and you go ahead and dip it directly into the glue, the dermabond, and then just very quickly paint around each of the edges. This is the only step that needs to be done rather quickly because the glue will dry fast, and you want it to dry obviously on the patient's arm and on their skin. Once you've got it all taped up, you're going to hold it and align it. We've just used red dots here, but you'll obviously see the blister holes when you're finished, and then place it down onto the patient's arm. Using the template, you can kind of go along the outsides of each of the different wells to hold everything firmly in place and make sure everything's compressed as it dries. Give it about 5 minutes before you insert the challenge fluid. Some researchers use 10% autologous fluid. This allows for a more viable cell extraction. We've used normal saline. We've also used irradiated bacteria as a direct challenge. You might want to check with your IRB as well as potentially the FDA, since these challenge inserts can constitute a investigational new drug. But the wells will hold about 1 milliliter of liquid, and from there you just want to go ahead and put these little plastic insert caps in place. Anytime you manipulate an individual well, you want to brace that well up against the skin with one hand while you put the cap in or remove the cap with your other hand. Once we have all the caps in place, what we like to do is wrap everything in Coban. It's probably excessive given the glue and the stickiness of the Duoderm 4x4 there, but this keeps anyone from bumping it into anything, or also allows the patients to walk around without too many questions as to what's going on. So this sits for however long you'd like. We typically let it sit for 24 hours. But in our earlier studies, we had accessed it earlier to see the various time points in terms of cytokine accumulation and cell infiltrate. Just brace carefully anytime you're unwrapping the Coban to make sure that it does not displace the glued caps. And then with sterile forceps or hemostats, you can remove the cap multiple times and you can replace the cap. The caps are going to be single use per individual patient, but you can use it over and over again during an experiment. This will allow you to access the fluid as frequently as you'd like. So in our experiments, we simply extracted the fluid at 24 hours, but you can also check at multiple time points. So the data shown here are IL-17 accumulation at 24 hours. On figure C, you can see the TNF accumulation for the wells with a saline challenge, as well as a well that contained irradiated methicillin-resistant Staph aureus. And then we can extract the cells, which is shown in panel E, and then ex vivo culture those infiltrating cells, run flow cytometry on those cells, as well as any other cellular and immunologic functional assay you'd like. The viability, as stated, is much better if you use 10% autologous serum, but you will still be able to get a significant number of cells out, most of which will be neutrophils. One of the most fascinating findings of our blister challenge models is that we can find cells with surface receptors that are unique to the cell population in the infiltrating blister that are not present in the peripheral blood. And what that means is that the blister process is not sorting cells out that are in the blood and selecting that population, but that the process of entering into the blister through the skin is actually inducing a physiologic change in the cells in ways that we can pick up. So the most painful part of the procedure is removing the whole apparatus when you're done. It's a little sensitive because of the blistering area. Definitely want to have a 4x4 or a chuck ready to collect any additional fluid that's left over. If they have hairy arms, they should be warned that it's going to hurt. One thing that we've learned is that the standard 4x4 that has the individual fibers, you cannot use that when you're bandaging the patient up. You're going to want to use one of these non-absorbent fibers. We've also used this Primapore just because it's a very large version of that can cover the whole area at once. But the ones that have the individual fibers will heal into the wound itself, and then when they go to do a dressing change, it'll actually tear and reopen the wound. The wounds are extremely superficial and should heal rather quickly. You can tell the patient that post-bandage care is fairly straightforward. Keep the area clean. You can shower immediately. You can use standard bandage techniques. We send them home with some of the non-absorbent 4x4s and Coban or the Primapore bandages, but even regular Band-Aids will work. The wounds will begin to re-epithelialize very quickly. They will have noticeable scabs, particularly since they will be 4 to 8 of them that are evenly spaced and of the exact same size. But those scabs will stay in place for about 4 to 6 weeks before they become far less prominent, to which the patient would have to point out to somebody that a procedure was done to their arm. Scars typically do not form. We've performed this on about 40 healthy adults and several patients with STAT3 deficiency and have not seen any long-term scarring. After about 4 to 6 months, you won't be able to tell that any procedure has been done. The residuals will have completely faded away. So if you have any other questions, my contact information is shown here. We hope this is useful to researchers who are interested in keratinocyte biology or in vivo responses to various environmental or infectious challenges. Thank you for watching.